So now that you just mentioned about insurance, I'm curious, because they, like in orthopedic physical therapy, they limit the number of visits. So how does it work with peds? Because you know that is 10, 20 sessions are probably not going to be enough. He's going to need like long-term treatment and all of that. So how does it work?
It's really interesting. And I think that the Affordable Care Act has had a positive influence on that in the pediatric world, because what was happening in pediatrics a lot is that a lot of the children that you work with have really large scale medical conditions at birth. And so before the Affordable Care Act became law, insurance companies would set lifetime caps on expenditures. And some of these children were reaching those caps in the first or second year of their life, which then made them uninsurable. Which, think about it, they've used up everything they had in their first year or two just to keep them alive. And then there's nothing left. So I think that the Affordable Care Act, by eliminating lifetime caps and eliminating the pre-existing conditions as a mechanism of eliminating these high-risk individuals from the insurance pool, has had a positive effect in pediatrics. But we still have annual caps in expenditures and in number of visits that are allowed for intervention, for rehab interventions like physical therapy. And, one of the big challenges is, how do you allot those visits over a year, for example, or over the lifespan of a condition? So you may not have a lifetime cap on physical therapy or on expenditures, but you might have a lifetime amount of visits of physical therapy for a particular condition. So if that child has a genetic condition, and they have 30 visits per condition, that 30 visits, their genetic condition is not going to change anytime soon. We don't have the medical technology for that. So then what? And then there's also the consideration that a lot of medical conditions that used to be terminal, not immediately, but maybe prior to reaching adulthood, like some of the muscular dystrophies or cystic fibrosis, are now no longer such. So now we need to consider that these children are going to become adults, whereas in the past, we didn't need to consider that they were going to become adults because they weren't going to live that long. And so we need to ration the care still, despite that lack of lifetime cap, sometimes annually or sometimes over a lifetime of a particular condition. So there are a couple of ways that you deal with that. First of all, there's the diagnosis itself. The physical therapy diagnosis doesn't have to be the medical diagnosis. So a physical therapy diagnosis might not be the genetic condition or the medical condition, but it might be the specific problem that brought that person to physical therapy right now. So it might be a gait problem, or it might be a pain problem, which might be different during the next episode of care. But then there's still that idea of how to very consciously schedule your year's worth of benefits. And so some clinicians will provide a very infrequent schedule of physical therapy over the course of a year. So maybe 2 visits a month for a year. Or sometimes they'll provide a brief, intense episode of care, maybe daily for 3 weeks, and then a much less frequent schedule of therapy visits for later in the year. So a lot of physical therapists will see, maybe in January or February, these booster episodes of care after the new calendar year begins or the new insurance year begins, and then save some visits for later. And then there's also the multiple revenue streams. So some children will receive physical therapy in school through the school year, and that's different from what's covered by your insurance company. And then they may go to outpatient therapies for goals that are not educationally related, so or for medically based or functional training based physical therapy. So there's a lot of different ways you need to look at the system And the truth is, it's really hard on a physical therapist to keep all of that in mind and do what's best for their patients. When I became a physical therapist, nobody taught me about the business of physical therapy. As a matter of fact, one of my professors who taught the professional behaviors course in my first year of PT school, who eventually became the president of my state chapter of American Physical Therapy Association, said in the most sarcastic voice, chiropractic students take business courses in chiropractic school, like they dirtied their hands somehow by knowing what they needed to know in order to keep their doors open. And truthfully, it's becoming harder and harder for physical therapists to keep their doors open. Reimbursement rates are decreasing. And especially in pediatrics, it's very hard to see more than one patient at a time. In an orthopedic practice, you might schedule 4 patients in an hour, and each one gets 15 minutes of individual attention. And then you're sort of keeping your eye on them from across the room while they're performing an exercise and providing correction while you're with a different patient on the table right there in a big open gym. That doesn't tend to work very well, especially with young children. So, with low reimbursement rates per session or caps per visit in the number of codes that you can bill and the like, I feel like therapists who graduated when I did really don't have the business background to be able to do that in pediatrics. Like, we need to take additional coursework in order to keep that going.